it seems like we have a good list to start with. But I want to say good morning to everybody again. Welcome to our Longevity Physical Therapy educational series. Our goal is to deliver high quality, clear and concise health information to our community so that we can help you live your best in 2021. It's been a very challenging year last year. However, I know we are transitioning into, hopefully, fingers crossed, somewhat of a more normal state of being, what with the vaccinations going out and what with our hopefully numbers starting to get better controlled. Although I understand there's still a lot of challenges out there. So everyone, please continue to stay safe, continue to stay with your precautions, even if you have been vaccinated. And as well, if you are enjoying being out and coming into our community and doing things along those lines, know that our highest priority is to keep everybody safe. So we welcome everybody here again. Today, we have a very, very special talk for each of you. Our topic today is on sleep and its impact on your health. Today, we are talking about sleep and its impact on your health. We have a very special guest here. We have Dr. Sonia Ancoli Israel. She's going to be giving us a talk today on sleep. But before we get there, I'm going to encourage everyone to please turn on your cameras. And this is just out of courtesy for our speaker so that she can see who we're speaking to, who we're engaging with. As well, we will be having a question and answer panel at the very end. And I know some of these topics are very broad, they're very sometimes very complex. So if you do have questions, feel free to write them down and we'll have some time at the end to answer some of those questions. Or if there are certain things that just come to your mind that you want to make sure you write down, please use the chat feature to write down your questions and we'll try our best to get to them at the end, okay? But today here with us, and I'm going to just spotlight her as well with me. This is Dr. Ancoli Israel, Ph.D., and she's a professor emeritus and professor of research in the Department of Psychiatry and the Center of Circadian Biology at the University of California, San Diego School of Medicine. Dr. Ancoli Israel has done her studies and her education in several different places, finishing with her PhD in the University of California, San Francisco. Her expertise is in the field of sleep disorders and circadian rhythms, particularly in normal aging and neurodegenerative diseases, and in cancer. Her research has included studies on the longitudinal effect of sleep disorders on aging, therapeutic interventions for sleep problems and dementia, and in the relationship between sleep, fatigue, and circadian rhythms in cancer. She is the past president of the Sleep Research Society and past president of the Society for Light Treatment and Biological Rhythms, and was on the founding executive board of the National Sleep Foundation. So as you can see, she is the top expert in this topic we're going to talk about today. She's published regularly in medical and psychiatric journals with over 500 publications to her name. So we're excited to have her here with us today. So once again, I'd like to remind you all, if you have questions, please submit them in the chat or please hang on to them. We'll have some time to answer. So without further ado, I'm going to invite Dr. Ancoli Israel to start us off and give us our talk for the day.
Thank you so much, Joe. Thank you both for the invitation to be here to speak to everyone. It's really my pleasure. And I look forward to hearing all your questions at the end. So we're gonna spend the next approximately 30 minutes talking about sleep and why sleep is so important for our health. What I'm gonna do is explain to you what controls our sleep-wake cycle, what is insomnia, what are the consequences of not getting enough sleep at night? How do we treat insomnia? And then I'm going to talk just very briefly about some other primary sleep disorders whose symptoms might mimic insomnia. If you have a question about a sleep disorder I haven't covered, I'm happy to try to answer that at the end as well. So let's start with what controls our sleep. I know this looks like a complicated slide. Actually, Joe, can you see my arrow, my pointer? Great. All right. So I'm going to walk you through this. It's not really complicated. Our sleep is controlled by two things, what we call our homeostatic regulation of sleep, our homeostat, which is our sleep drive. That's our need to sleep. And then the other part is the circadian system. Circadian means about 24 hours, and it refers to our biological rhythms. So if we start by looking at our sleep drive, our need to sleep, or that drive to sleep, starts out very low when you first wake up in the morning, because we were just asleep. As we go throughout the day, this need or this sleep drive increases until it gets so high that we can't stay awake anymore. We fall asleep and then it dissipates because we're asleep until the next morning when the whole thing starts again. What keeps us from falling asleep as that drive to sleep increases? It's our circadian alerting system. It also starts out low, increases throughout the day, and it's when these two systems get to sort of this balance point that we're able to fall asleep. The alerting system then also dissipates or decreases until the next day when the whole thing begins again. You see, we have two other curves here. One is our melatonin curve. So melatonin is a hormone that's secreted in our brain, and it's secreted in darkness. I'm not talking about the melatonin you buy over the counter now. I'm talking about the melatonin we make in our brain. And as I said, it is secreted in darkness, which is very important because that's one of the reasons, and we'll talk about this a little later as well, why it's so important that your sleeping environment, your bedroom, be very dark. And you see that increases as darkness falls and then decreases as there's more and more light. And then this other curve is our core body temperature curve. Core body temperature drops at night, that's when we get sleepy, rises in the morning, that's when we wake up. But you see there's a dip here in our core body temperature, and that's why we get sleepy after lunch. It's a very normal time to want to take a nap. And obviously there are whole societies who do that or used to do that, like the siesta. But if you look at those cultures, you will notice that they have dinner much later than we do. They go to sleep much later than we do. So in a 24-hour period, they're still getting the same amount of sleep. They're just doing it in two bouts. And in our culture, we tend to do it in one bout. And physiologically speaking, the way they do it actually makes more sense. So it's when these things become out of sync that we start having difficulty sleeping. So essentially, what this is saying is in the first part of the night, we're asleep because we've been awake all day. Our sleep drive is very high. In the second part of the night, we're asleep because our circadian alertness is low. During the day, in the first part of the day, we're alert and bright and awake because we just slept all night. So the homeostat, that drive to sleep, is low. But in the second part of the day, we are able to stay awake because the circadian alertness is high. So it's really the balance between these two things that control when and how we sleep. So what is insomnia? I really like this slide. I'm gonna see, hold on, yeah, there we go. I needed to get rid of everyone's picture so I could actually see the slide. So I like this slide because it really captures some of the byproducts, the symptoms of insomnia. My creativity diminishes, my irritability increases, my disposition suffers, my outlook is gloomier, my muscles feel weaker, energy is kaput. Some days I'm too tired to accomplish anything, but I'm still unable to nap. Odd sensation. I feel as if I've been deprived of sleep and I'm exhausted, but at the same time, as if I had drunk 5 cups of coffee and I'm overstimulated. So look at some of these words that I've bolded, because these are not usually things you associate with insomnia. Irritability, gloomy or depressed, weak, no energy, unable to sleep. So even though you're so tired, you still can't sleep during the day. So these are all things to keep in mind, that if you experience these symptoms, to think about whether you're just not getting enough sleep at night. So what actually is insomnia? We define insomnia by duration and by symptoms. So insomnia is defined as being dissatisfied with either the quality or the quantity of sleep, so how much you're sleeping or how well you're sleeping, and difficulty falling asleep or staying asleep. So it could be that you have difficulty falling asleep at the beginning of the night. It could be that you wake up in the middle of the night and can't get back to sleep, or it could be that you're waking up too early in the morning and can't get back to sleep. But in addition to the difficulty with sleep at night, you also have to experience some daytime impairment. So that inability to sleep has to have an effect on how you function during the day. And that could mean being fatigued, having problems with memory, mood, behavior, performance, anything at all like that. Insomnia is not the same, however, as sleep deprivation. So insomnia, you have enough opportunity to sleep, you're in bed long enough, you just can't get the sleep that you need. In sleep deprivation, you have no trouble sleeping, but you're just not in bed long enough. However, the consequences of not getting enough sleep, whether it's because of sleep deprivation or insomnia, are in fact very similar. And I should add here, because I realized I didn't put a slide in about it, how much sleep should you be getting? What is the right amount of sleep? And for adults, the recommended amount of sleep is 7 to 8 hours. So if you're sleeping less than that, you are likely sleep deprived. Now, I mentioned how insomniacs have difficulty napping. So even though they're really tired, that same trouble sleeping that they have at night, they also have during the day. And that's because insomniacs actually are hyperactive, not hyperactive in their behavior, but hyperactive in their body and their brain. So it really doesn't matter what the details are here, but the point is that we do see a lot of hyperactivity in different hormones, in our metabolic rate, core body temperature, heart rate, et cetera, et cetera. And if you look at this plot, this is a plot of cortisol, which is something we have in our bodies. And what you see, the green are the patients with insomniac, the yellows are non-insomniac patients. And you see that in the insomnia patients, the cortisol is quite a bit higher, which suggests more activity in the brain, which is one of the reasons patients with insomnia have difficulty sleeping. How common is insomnia? Well, about 20% of the adult population complain about sleep, but don't necessarily meet the criteria for a diagnosis of insomnia. 10% will meet the diagnostic criteria. But if you go into any clinical practice, like your primary care, your physician's office, we find that about 50% of those patients will have insomnia. And there are many conditions that are comorbid with insomnia. Notice I say comorbid. I don't say they cause insomnia, but they appear at the same time with the insomnia. And that would include medical and psychiatric illness, many of the medications that we take, changes in our circadian rhythm, in our biological rhythms, and primary sleep disorders. And I'm going to touch at least a little bit now on each of these. So if we start with medical conditions, pretty much any medical condition that causes discomfort will be comorbid or associated with poor sleep, whether it's the pain from headaches, arthritis, neuropathy, the neurodegenerative process, Alzheimer's disease, Parkinson's disease, heart disease, pulmonary disease, nocturia, which is defined as getting up to pee 2 or more times during the night. All these things can be associated with poor sleep. But that doesn't mean that if you treat, for example, the pain, the sleep will automatically improve. As I said, one is not causing the other. They are associated with each other. So the best approach is to treat both at the same time, and then you get the best response both to the pain and the sleep, as an example. So then the other reason that we can have difficulty sleeping is because of all the medications that many of us take. So here's Marvin. Marvin's sitting with his little cousin. He says, how come Grandpa never goes to a job like other big people? Because he works at home, silly. See, he runs a drugstore. And here you see Grandpa with all his medications. And this is particularly true in older adults, but even younger adults take a lot of drugs, whether it's prescription drugs or over the counter. And these can also have an effect on our sleep. So let's start with alcohol. I know alcohol isn't considered a drug, but it's a good place to talk about it. Many people will use alcohol to help them fall asleep. And the alcohol does make you sleepy initially. But several hours later, when the alcohol leaves your bloodstream, it wakes you right back up again. So if you drink right before you go to bed, you might fall asleep faster, but a few hours later, you're going to wake up and then have a hard time going back to sleep. Or if you drink a lot with dinner, you might be sleepy initially right after dinner, but a few hours later, when it's time to go to sleep, you might be wide awake. So alcohol causes insomnia. Caffeine, you all know the problems with caffeine. It does affect your sleep, and we'll talk about that a little later. Nicotine, in case you're still smoking, here's one more reason to stop. But then let's look at the prescription medications. Antidepressants, corticosteroids, decongestants, beta agonists, antagonists, statins, et cetera, et cetera. Many of these drugs are associated with poor sleep. And sometimes by just adjusting the dose of the medication or the time of day that you take it. For example, an activating drug should be taken early in the day. A sedating drug should be taken later in the day. And by making those adjustments, you can often have a very positive effect on someone's sleep. Okay, so why do we care if you don't get enough sleep at night? Well, there are indeed consequences. There are problems with cognitive function, with memory, with concentration. There's negative quality of life measures. There's a higher incidence of general poor health, especially in pain. There's a future risk of psychiatric disorders. So everyone sort of is aware that if you are depressed, you have difficulty sleeping. But if you have difficulty sleeping and it goes on untreated for a very long time, you're at greater risk for developing depression. Or if you've had depression, you're at greater risk for a relapse if you don't get the sleep problem treated. There are problems with performance, increased absenteeism, increased risk of accidents, and increased healthcare costs, not because people see their doctor for insomnia, but they go to see their doctor because they're just not feeling well and they don't know why. And sometimes it takes a long time for either the doctor or for you to realize that it's the lack of sleep that's causing these problems. Let's look at some of these. Here's some data on insomnia and performance at work. Workers report sleepiness causes difficulty with, as you can see, concentrating, handling stress, solving problems, making decisions, listening to your coworkers, or relating to the people around you. And you get a reduction in the amount and the quality of work. So if you're not getting enough sleep, it's probably affecting your ability to perform well on your job or at school. Absenteeism, you can see the insomnia group has many more days, significantly more days of being absent from work per year compared to those with no insomnia. Accidents. People with insomnia are 3.5 to 4.5 times more likely to get into a car accident. And it's not because they're falling asleep. Remember, insomnia patients can't sleep during the day either. It's because of the lack of attention and concentration, or the difficulty in paying attention and concentrating, that ends up causing these accidents. All right, so what do we do about it? If we have insomnia, how do we treat it? And this is where I'll probably spend the most amount of time, because this is really important. And by the way, counting sheep is not a bad thing if it helps you calm down and sort of focuses your mind so your mind isn't wandering. But let's back up just a little bit. So we talk about Spielman's model of insomnia, the 3 Ps. We've got our predisposing, our precipitating, and our perpetuating factors. Predisposing factors are those things that make it more likely that you will develop insomnia. If you happen to be an anxious or depressed person or have that type of personality, if you tend to worry and stress a lot about anything, but especially about sleeping, oh my God, I know I'm not going to be able to sleep. Or if you have a decreased homeostatic sleep drive, remember that drive, that need for sleep is part of what helps us fall asleep. And if that's overall decreased, you'll have a harder time with sleep. But that doesn't mean that you will develop insomnia. It just means you're more likely to if other things happen. And some of those other things are the precipitating factors. Things like what we just talked about, having a medical or psychiatric illness, taking drugs, shift work will do it. or just having stress in your life. And remember, stress doesn't have to be negative. It could be a positive stress, like you're getting married or something, you're starting a new job. It's a good thing, but it could still be stressful. And of course, COVID falls into all of this as well. All that we've been going through in the last year and the pandemic has been very stressful and has affected sleep for many, many people. But even with the precipitating factors, it doesn't mean you'll have chronic insomnia. You might have difficulty once in a while. It's when you start into the perpetuating factors that you tend to fall into the chronic insomnia condition. And often these perpetuating factors are all the things that we try to do to improve our sleep that actually make it worse. And when we treat insomnia, what we try to do is break this connection between the perpetuating factors and everything else. So how do we do that? There are 4 cardinal rules for good sleep. This is probably the most important slide of my whole talk. Number 1, rule number 1, don't spend too much time in bed. If you want to sleep, let's say 8 hours, remember I said 7 to 8 is the amount of time you should be asleep. So let's say if you want to be asleep for 8 hours, you should only be in bed for about 8.5 hours, not 9 or 10. What does the insomnia patient do? You know, I didn't sleep a wink last night. I'm going to go to bed extra early to try to get more sleep. By extending time in bed, sleep actually becomes more fragmented and more disturbed. So reducing your time in bed to keep it close to the amount of sleep that you want is one of our first rules. Rule number 2, get up at the same time every day, 7 days a week. That means no sleeping in on weekends. Now, of course, now when all of us have been working from home, we have been sleeping more. Many of us have been sleeping later in the day. And I don't care what time you get up, as long as it's the same time every day. And what this does is it helps stabilize our rhythms. So our circadian rhythms, our biological clock, need one stable point around which they can fluctuate. You can't control what time you fall asleep. You can only control what time you get up in the morning. So it's very important to get up at the same time every day, no matter how much or how little you slept the night before. Rule number 3, don't go to bed unless you're sleepy. If you're not sleepy and you go to bed, all that's going to happen is you're going to toss and turn and get upset about the fact that you're not falling asleep. Often what happens, especially if you're part of a couple and your partner, say, likes to go to bed at 10 o'clock, but you don't get sleepy till 11:30. So you go to bed at 10 to go to bed together. Your partner falls asleep and you lie there staring at the ceiling for an hour and a half. That's only going to make your sleep worse. You go to bed when you're sleepy, not when the clock says, oh, it's time to go to bed, 10 o'clock, 11 o'clock, I should go to bed, or someone else is going to bed. Wait until you're sleepy. And rule number 4, don't stay in bed unless you're asleep. So if you get into bed and you find you can't fall asleep, or you wake up in the middle of the night and you can't fall back to sleep, you get out of bed. Now I'm going to go into these things in a little more detail, but in general, these are our 4 most important rules. So coffee, we mentioned nicotine before. I love this cartoon. I think of this little bear lying down as Mrs. Bear, and this is Mr. Bear. And Mrs. Bear says, how many times have I told you no coffee after September? Now, of course, if we were live, you would all be laughing and I would hear you. But caffeine does affect your sleep. I have patients telling me all the time, oh, I can have a double espresso at bedtime and it doesn't bother me. But if I recorded your sleep, I would show you it does. And what we tell people is no coffee after lunch, particularly if you have difficulty sleeping. Caffeine has a very long half-life. And by the way, caffeine is not just coffee and teas. Many of my patients say, oh, I only have green tea. Green tea has loads of caffeine in it. Diet sodas have more caffeine in them than the not diet equivalent. So Diet Coke, more caffeine than regular Coke. So no caffeine. Notice I don't say no coffee, no caffeine after lunch. Whoops. Suddenly my slides aren't, there we go. All right, now, again, I wish I could hear your answer, but my question to you is, what do you do? What's the first thing you do when you wake up in the middle of the night? And I'm sure you're all saying, go to the bathroom. But I bet even before you go to the bathroom, you'll look at the clock. Very normal thing to do. But what happens when you look at the clock? First of all, you have to take yourself from what we consider transitional sleep to full awakening, to comprehend that it's 1:20 in the morning and you want to be asleep. By taking yourself to full awakening, it's now harder for you to go back to sleep. Remember, you need time for that sleep drive to increase to make you sleepy enough to fall back to sleep. So that makes it much harder. So the key is get rid of the clock. There is no reason to have a clock in your bedroom. If you need an alarm so that you get up at that same time every day, stick your clock, which these days is usually your phone, stick it under the bed or in a drawer, somewhere where you're not tempted to look at it, but you can still hear the alarm if you need that to wake up in the morning. There is no place for a clock in the bedroom. Now you're going to tell me, but when I wake up, I have to get up to go to the bathroom. Well, first of all, needing to go to the bathroom doesn't usually wake you up. Usually you wake up first and then you realize there's pressure and you decide to go to the bathroom. So if when you first wake up, you just keep your eyes closed, you have a much greater chance of falling right back to sleep. If though you suddenly feel, oh my God, I really do have to get up, one of the key things is try not to turn on a lot of lights. I love it. This picture is from one of those magazines on the plane, the Sky Mall, and I wish I had actually bought the slippers rather than just taking the picture because it's brilliant. You can see where you're going, but you don't have too much light. Why do we care that there isn't a lot of light? Remember, our melatonin is secreted in darkness. When there's light in your bedroom, it's telling your brain, stop secreting melatonin, it's time to wake up. So if you need a night light so you're safe, go ahead and do that, but try not to turn on too many lights. So keep your room very dark. You want a quiet environment and you want a comfortable temperature, not too hot, not too cold. That's a very personal thing. And sometimes that's a problem when couples have different temperature needs. You need to work that out. But the key is not too hot, not too cold, very dark and quiet. We call those sleep hygiene rules. There's some other ones. So we talked about alcohol, caffeine, nicotine. We talked about the clock, the environment. You want lots of bright light exposure during the day. Light is the strongest cue our body has to know when to go to sleep and when to wake up. And especially morning light helps stabilize or strengthen our biological clocks, our circadian rhythms. So it's really good to get out during the day, especially in the morning, and get your exposure to bright light. We talked about avoiding bright light at night. We want that environment dark. Exercising, the more you exercise, the more physically fit you are. So all those PT exercises that you're being given, go ahead and do them, but don't do them too close to bedtime. If you exercise, ideally around 6 hours before you want to go to sleep. You know, when we exercise in general, our core body temperature increases. It takes about 6 hours for it to start dropping. Remember, I told you when core body temperature drops, that's when we get sleepy. Not always possible to time it that way, but the key is you don't want to exercise close to bedtime. And this last one, I know it sounds funny, but you know, in our busy lives, often the first moment we have to think is when we get into bed at night. And that's the wrong time to start thinking. So what we say is find 10, 20 minutes, 10, 15 minutes maybe during the day when you can sit down quietly, turn off your phone and worry. That's your time to think about all those things that you tend to think about when you get into bed at night or in the middle of the night. And if you do that every day at the same time, your brain becomes conditioned to worrying at, 10 to 10:15 in the morning rather than in the middle of the night. And if you do start doing it in the middle of the night, you can remind yourself, wait, I have from 10 to 10:15 tomorrow to do this. I don't have to do this now. Many people find this a very good way to quiet their minds. So I want to spend a few minutes about some of the specific behavioral therapies that we do. These therapies combined are called cognitive behavioral therapy for insomnia, or CBTI for short. Many studies have shown that CBTI is the most effective treatment for insomnia, much more effective than any sleeping pill that you might take. And the duration is much longer. So essentially, you've heard the expression, you can give a man a fish or you can teach him how to fish. I could teach you how to sleep, which is what the behavioral therapies do, or I could give you a fish, I could give you a sleeping pill. And I would much rather teach you how to sleep or reteach you how to sleep than to give you a pill. This way, when you've learned good sleep habits, no matter when you have a bad night's sleep, you know what to do to make it better. So one of the first therapies we teach people is called stimulus control therapy. It's considered one of the most effective behavioral treatments. It's good for people who have difficulty falling asleep or staying asleep. And it's basically based on the principle of classical conditioning. What that means is when you have difficulty sleeping, that leads to stress, anxiety, right? You're tossing and turning and you're getting really tense and upset that you can't fall asleep. Because this takes place in your bed, you start associating the bed with the stress. You look at the bed and you go, oh God, I know I'm not going to be able to sleep. What we do with stimulus control is we try to break that association. We want you to look at the bed and think, sleep. And the way we do that is we tell you to get out of bed if you're not asleep. Remember, I told you that was one of the cardinal rules. So if you're not asleep, you want to be out of bed. So you associate not sleeping with something else and not with a bed in the bedroom. Over time, your sleep drive will increase. We're actually sleep depriving you, which helps your sleep drive increase. You start falling asleep faster, and then you start associating the bed with falling asleep quickly instead of with tossing, turning, and not being able to sleep. So the bed actually becomes a cue for sleeping. So our actual rules are, first of all, right, you get up at the same time every day. We talked about that. And we often negotiate that time with the patient. So I'm not going to tell you you have to get up at 6 or 7. I would, your doctor who's doing this with you should be working with you to find out what that right time is for you to get up every day. The bed is only for sleeping. We don't read in bed. We don't watch TV in bed. We don't play games on our phone or computers in bed. We don't pay bills and play in bed. It's for sleeping because you're trying to associate the bed with sleep. Now I say in sex, but even that, only if that's satisfying. If it's not, if it's frustrating for any reason, you don't do it in bed. The bed, I don't care where you do it, but just not in bed. So again, you'd be laughing if I could hear you. So the bed is only for things that are relaxing and are conducive to sleep. You only sleep in bed. You don't go napping and sleeping on the couch or in your comfy chair. You sleep at night in your bed. Again, you want to associate sleeping with your bed, not with any place else. You only go to bed when you're sleepy. Remember, that's another one of our cardinal rules, because you don't want to be tossing and turning and not sleeping. Now, what we say is if you get into bed at night or in the middle of the night and you haven't fallen asleep in about 20 minutes, you get out of bed. But remember, you don't have a clock. You don't know it's 20 minutes. So what this really means is at the point that you start getting tense, tossing, turning, etc., you get out of bed. I never want you in bed feeling angry and tense that you can't sleep. You go into another room, you do something quiet, relaxing, hopefully without too much light, because remember, you don't want a lot of light at night. But if you're going to read, you can't do it in the darkness, obviously. So just not too much light. And if you're going to read or watch TV, you don't do something that's going to suck you in. You know how you start watching a movie and you're starting to get sleepy, but you really want to see the end of the movie, so you force yourself to stay up. Or you're reading and you really want to read one more chapter. Read a short story or a magazine where it's easy to put it down. Watch an infomercial at night that's easy to turn off. Because as soon as you start getting sleepy, you want to get back into bed so that you catch that sleepiness moment and fall asleep in your bed. And of course, no napping during the day, because that would decrease that sleep drive again. So that's called stimulus control. The other therapy that we do, and we'll usually do one or the other, sometimes we combine them. The other one's called sleep restriction. This is particularly good if you're spending too much time in bed. It improves the continuity of your sleep by decreasing the amount of time in bed, which then increases the sleep drive, because again, we're sleep depriving you. And we have you keep, actually for all of these, we have you keep a sleep diary. It's usually electronic or a piece of paper where you write down when you go to bed, how long you think it took you to fall asleep, because there's no clock, how many times you woke up during the night, how many times you think you were awake, things like that. And this is also a good therapy for both difficulty falling asleep or staying asleep. So sleep restriction is all about improving sleep efficiency. What is sleep efficiency? It's the amount of time asleep given the amount of time you're in bed. In the ideal world, that would be 100%, right? You'd be asleep the entire time you're in bed. but it takes everyone at least a few minutes to fall asleep. Everybody wakes up once or twice during the night. So we consider a sleep efficiency of about 90% or above to be good sleep efficiency. But most people with insomnia have a very low sleep efficiency, maybe about 70%. So our goal is to get people to about 85%, and we compute the sleep efficiency from the information you give us on your sleep diary. So again, we have a fixed wake-up time, and we work backwards from that. So if you tell me that you're generally asleep for 5 hours and your wake-up time is 6, we don't allow you to go to bed till 1 in the morning. I know you're all looking at me like, what? But yeah, we're going to limit your time in bed to the amount of sleep that you usually think you get. And when your sleep efficiency hits 85%, you're allowed to go to bed 15 minutes earlier. And we keep increasing that time in bed as your sleep efficiency improves by letting you to go to bed earlier and earlier, but your wake up time stays the same. And in this way, we slowly improve your sleep, increase your sleep, but actually get you to sleep. So it's all about sleep efficiency. Okay, what about, and that's those are the main behavioral treatments. It's the cognitive behavioral therapy for insomnia, along with those sleep hygiene rules that I gave you, the dark environment, no caffeine, no alcohol, et cetera, et cetera. Okay, but sometimes it is appropriate to use a sleep medication. We already talked about the problem of alcohol. I won't repeat that again. Antidepressants and antihistamines, well, let's take them one at a time. Antidepressants are often used off-label. That means they're not approved for sleep, but because they tend to make you drowsy, many physicians will give you an antidepressant to help you sleep. Data show that these antidepressants generally are not that effective in the long term for helping you sleep. If you're taking one, the most common one that's used for sleep is trazodone. If you take it and you find that works for you, great, you don't stop. But it's not something that we would often recommend. Antihistamines also can make you very sleepy. Diphenhydramine, that's what's found in all the PM drugs that you buy over the counter, you know, Tylenol PM, Advil PM, Excedrin PM, et cetera, et cetera. These drugs, although may work initially, they don't work long-term. And they have side effects that, especially in the older adult, can be quite concerning. So we do not recommend that these PM drugs be used on a regular basis. If you're using them once in a while, you know you have a stressful day tomorrow, and so you take it tonight, that's okay. But I wouldn't use them on a very regular basis. And then we get to those drugs that are actually approved by the FDA for sleep. This is the list. You all will be getting a handout later on, so you'll have all these slides. You don't need to be copying this down. But this is the list of all the drugs that are approved by the FDA for sleep. And I want you to notice a couple things. Some are approved for difficulty falling asleep. Some are approved for people who need to help staying asleep during the night. And if you are approved, if you only have a limited amount of time to stay in bed, because look at the required inactivity. Most of them say 7 to 8 hours. If you can't be in bed 7 to 8 hours, you should not be using these drugs, because you will be hung over. You will still be experiencing some sleepiness when you need to be awake and alert. So the two questions your doctor should be asking before he or she gives you a medication is, first of all, what is your problem? Is it difficulty falling asleep or difficulty staying asleep? And then pick the appropriate drug. And the other question is, how much time do you have to stay in bed? So it's the combination of those answers that will help determine what the right drug is for you. They pretty much, according to the data, they all work fairly well, somewhat well. Many of them are recommended not to be used for long-term use. Some of them you can use a little longer than others. They're all prescription drugs. They all have side effects, because every single medication out there has side effects. So you have to figure out with your doctor what might or might not work for you. Okay, let me touch briefly about some of these other sleep disorders, and then we will open it up for questions. So the first one that I want to spend a little time on are our circadian rhythm disorders. So our typical pattern, as we discussed, most people get sleepy around 10 or 11. That's when our core body temperature drops. We sleep our 7 to 8 hours, core body temperature rises. That's what wakes us up. So we sleep somewhere from maybe 11 to 6, 12 to 7 or 8, something like that. But at different times in our life, this pattern shifts. Teenagers, adolescents, young adults have what we call a delayed sleep phase. Their core body temperature is not dropping till maybe 1, 2 in the morning. And adolescents actually need 9 to 10 hours of sleep. So if you do the math, they're not waking up till 9, 10, 11. What happens to teenagers? They sleep half the day away, right? When we yell at our teenage kids or grandkids, stop being so lazy, stop sleeping the whole day. But in fact, that's very normal for them. That's why early start times in high school are such a big deal, because for them to sit at a math class at 7 or 8 in the morning is like us trying to sit in math class at 3:30 in the morning. Very hard to stay awake. So that's a delayed sleep phase. Now, most people, as they grow out of young adulthood into full adulthood, shift or advance back to this typical phase, but some people stay delayed their whole life. Those are our owls. If you're an owl, you know you're an owl. Owls, if they try to go to bed, or even anybody who's delayed tries to go to bed at 10 or 11, will have what looks like insomnia, because it takes them hours to fall asleep. And then they have a very hard time getting up in the morning. Okay, let's keep going. So that people that don't stay owls come back to this typical phase. But as we continue to get older, the pattern continues to advance. So older people have what we call advanced sleep phase. We get sleepy earlier in the evening, maybe 7, 8, 9 o'clock. And if we went to bed at that hour, we would have no trouble falling asleep. We would sleep our 7 to 8 hours. But again, if you do the math, that means we're waking up at 3, 4, 5 in the morning. What is the biggest complaint older adults have? I'm waking up in the middle of the night. Here it is, the middle of the night, and I can't get back to sleep. And it's true, because physiologically speaking, their day is done. Core body temperature is rising. It doesn't matter that the sun hasn't risen yet. Their night is finished. Now, two scenarios, two things that happen with older adults. The first is that although they get sleepy at, say, 8 o'clock, they don't go to bed because they think, oh, who goes to bed at 8 o'clock? That's way too early. So they force themselves to stay up later, but they still wake up at 3, 4 in the morning. Now they're not in bed long enough to get a full night's sleep. You can't sleep 7 to 8 hours if you're only in bed for 5. So they're tired during the day. They take a nap somewhere in the afternoon. That nap decreases their sleep drive. Remember our homeostat? So they're able to stay awake later into the evening, but now they get into the cycle of not sleeping enough at night and needing to nap during the day. Second scenario, which is much more common, is they have an early dinner, right? They get sleepy earlier. They usually eat dinner earlier. That's why you see early bird specials in restaurants. After dinner, they sit down to watch TV or read, and what happens? They fall asleep. And they sleep maybe half an hour, maybe an hour. Then they get up and they get ready to bed. And what happens now? They're wide awake, right? That's our sleep drive again. The sleep drive hasn't had enough time to increase to make them sleepy enough to be able to fall asleep. Now they have difficulty falling asleep. They have difficulty, what they say is staying asleep, because they're still waking up early. And they come in to see their doctor and say, Doc, I have horrible insomnia. But it's not. It's an advanced sleep phase with that bad habit of napping in front of the TV in the early evening. And we treat these circadian rhythm disorders not with the same treatments of insomnia, but rather with light. Now, remember I told you light's the best cue for knowing when to go to sleep and when to wake up. So for the owl, we want morning light. So when you get up in the morning, you go outside, go for an early morning walk and get that bright light. The key is to do it without sunglasses, because the mechanism of the light helping our sleep is through our eyes, and the sunglasses will block all that great light. Sometimes we use melatonin as well in the early evening. This is a very low dose. Most people, if they're using melatonin, are using way too high a dose. We say about half or even a quarter of a milligram. And we're not using it to make you sleepy. We're using it to advance your sleep phase, to help you get sleepy earlier. So we recommend that you usually take it about 6 p.m. And that will help, especially in combination with a light, to advance your sleep phase. That is, help you get sleepy earlier and wake up earlier. For our older adults with this advanced sleep phase, we say get light in the evening. I use a light bulb because often the sun isn't out, but the truth is we tell these patients to get out as late in the day as possible while the sun is still out. Again, no sunglasses, to get their bright light exposure. And that will help delay their rhythm, help them stay awake later into the night and sleep later into the morning. Okay, very quickly, restless leg syndrome. This is a condition where people have these creepy, crawly sensations in their legs, which can only be relieved with movement. I'm going to let you read these 4 questions rather than reading them to you to save time, but you have to answer yes to all 4 to get the diagnosis of restless legs. If you answer only to 1 or 2, you don't have RLS. And if you have restless legs, you know it because it's such an uncomfortable feeling. There are medications that are used to treat RLS. So if you have this condition, definitely see your doctor. It is one of the reasons people have difficulty falling asleep at night, because their legs are moving so much and they're so uncomfortable. And the last thing I want to talk about is sleep apnea. Sleep apnea is a condition where people stop breathing in their sleep. If this is your airway, when you fall asleep, your airway collapses. And so even though you're trying to breathe, you can't, because the air can't get through. In order to start breathing again, you wake up, your airway opens, you go back to sleep, your airway closes. And this goes on for periods throughout the night. This is a picture I took of Brahms when I was in Vienna, and I'm pretty sure Brahms had sleep apnea. How do I know? First of all, he's older. Sleep apnea becomes more prevalent in older adults, but it's still very prevalent in younger adults as well. He's overweight. The more you weigh, the more likely it is that you have sleep apnea. And he's sound asleep. Who has a statue made of them sound asleep? I'm pretty sure he has sleep apnea. This is one of the symptoms of sleep apnea. Sleep is so disrupted at night that it's very difficult to stay awake during the day, and people fall asleep at what we would consider very inappropriate times, including driving. So it's a serious condition that needs to be treated. The other symptom is very loud snoring. So if you're sleepy during the day, or you snore loudly, or you've been observed to stop breathing at night, you should be evaluated and treated if you have sleep apnea. So let me conclude. Insomnia is a disorder. If you have difficulty sleeping at night, see your doctor and get yourself treated. It's usually coexistent with other medical conditions, medication use, or other sleep disorders. It has significant consequences, which is why you want to treat it. And there are good ways to treat it. There are approved medications, but really the behavioral treatment is the best approach. And with that, I'll just end with this. One night of insomnia is not the end of the world, but I do wish you a lot of very good night's sleep. And with that, I will stop.
Thank you, thank you, thank you. That was incredible. I took so much notes that it's filling up pages here. This is great. Thank you, Dr. Ancoli Israel. Now, I don't know if you've had the chance to also take some notes, but as Dr. Ancoli Israel said, all of you who are attending here today, we will be sending out a follow-up email on Monday with all of these, with the version of these slides that have that pertinent information that that she was talking about, with some of those medications and some of these things. A few things really stood out to me. So I'm going to take this time to just recap a couple of key points. But if you have some questions, this would be a good time to organize them. You can submit them in the chat box below, or later on when we open up for questions and answering, you can just raise your hand and I'll call on you. But a few big things that really jumped out at me were the cardinal rules for sleeping. Right, there are really 4 important cardinal rules of sleeping, of reducing your time in bed and really only using your bed for sleep, getting up at the same time each day, and not going to bed unless you're sleepy, or don't stay in bed unless you're sleepy. And I think for us, a lot of times that's really challenging, because we figure, hey, if I'm in bed, I can sleep longer, or I can drag out my sleep a little bit more. And it turns out that's really not the case.
Right. And it's really hard to get out of bed in the middle of the night, especially if it's cold. But you got to force yourself to do it. Yeah. That's probably the
Yeah.
hardest thing.
So thank you. So I do have a couple of questions prepped. Now, I think we're starting to see some questions. So I'm going to open up the time for some question and answers. If you do have some questions, please raise your hand and I'll make sure to let you know to unmute. But the first question that we have received, and this is a question that's coming from Barbara, and it talks about taking statins and wondering if that matters during the daytime or the evening time, maybe with regards to sleep quality or the effects of the medication.
Right. Statins are usually recommended to be taken in the evening. So you also have to balance, and it all comes down to our circadian rhythms. You have to balance when the drug is going to have the best effect for what the drug is going to be doing, as well as how it affects sleep. So if you're taking your statins in the evening, at night, at bedtime, and you're not having difficulty sleeping, I wouldn't change it. If you are having difficulty sleeping and that's the only drug you're taking, you could talk to your doctor and ask your doctor if it's okay to just try taking it in the morning and see if it makes a difference in your sleep.
Great, thank you. Another question that we had received, this is from Alan, and this is actually a question that I had personally as well as I was writing this up. Dr. Ancoli Israel, you talked about the different phases of sleep, or standard phase, advanced phase, and delayed phase. The question is pertaining to, is there any truth to the claim that the highest quality of sleep is early in the night? And if so, is it worth or not possible for night owls to gradually change their sleep patterns in a way to shift to earlier sleep schedules?
Okay, those really are two separate questions. Let me take the first one. So as we go through the night, we go through different stages of sleep. We have 4 stages of sleep. Stage 1, which is that transitional sleep. That's when you know you're not fully awake yet, but you're not fully asleep either, right? And that's why when we first wake up in the middle of the night, we're in that stage 1 and you don't want to take yourself to full awakening. Then we go stage 2 and stage 3, each one getting deeper and deeper. Stage 3 is our deepest level of sleep. And the last stage is REM sleep, or rapid eye movement sleep, which is our dream sleep. Our deep sleep tends to occur in the first third of the night. Our REM sleep, our dream sleep, tends to occur in the last third of the night. They are all important. So it's not true that the best quality is in the beginning of the night. That's when your deep sleep happens to be, but all our stages of sleep are important. Now, the second part was about shifting a delayed sleep phase. So first of all, if you're delayed and it fits into your lifestyle, certainly during COVID, a lot of delayed people were able to sleep according to their own rhythm because we didn't have to get up to go to work in the morning, or we could sleep later because if we were going to work, it was in the next room in front of our computer. So if it fits into your lifestyle, you don't have to shift. But if you do want to shift, the only way to really do it is with that bright light in the morning, as I say, sometimes in combination with the melatonin. So if you want to shift, that's the way to do it.
Yeah, thank you. It sounds like that light is really important for us in
Light
terms
is really
of.
important. You want to give your testimonial, Joe?
I do. So I recently returned from an overseas trip. I was in Taiwan, where day and nights actually flipped compared to us because it's 15 or 16 hours ahead, depending on daylight savings. And coming back on this past week, gosh, every morning when I wake up, the first thing I do is try my best to get out to see some sunlight, to keep myself up with using sunlight only. And then when I try to go to bed, it's like what Dr. Ancoli Israel said, keep my environments a little bit more, a little darker, a little bit more quiet, just so that I know my body is ramping back down. And actually, this was some insight that I had received from her when I was talking with her about this talk. So thank you. I'm good now.
And it's working, right? It works.
It is working. I'm here and I'm awake. And there are some other questions. Now, I'm going to group a couple of these questions up. There is one talking about listening to some sounds, music, or sleep stories in bed in terms of helping to go back to or to go to sleep.
Right.
Is there any research behind that there, Dr. Ancoli Israel?
Here's the thing. We don't have research on a lot of these things. If in general you don't have trouble sleeping, or you have just a little trouble and listening to music or something at the beginning of the night helps you fall asleep, then I don't mind you doing it. But if you're doing it and it's not helping you fall asleep, because sometimes we keep trying things even though they're not really working, then I don't want you doing that in bed. Again, you want to associate the bed with sleep, not with listening to music. But if it helps you, then it's okay.
Yeah, thank you. Some other questions, and remember too, we also have the option to ask questions live. We have maybe 5 or 10 minutes left. Looks like Rachel's got a question that we'll get to in a minute. There are some other questions here about taking supplements, or there's a CBD type drugs or magnesium. How are those related to how we sleep versus some of the medications we've discussed
Right.
earlier?
So the problem is we don't have good data on those. There are a lot of studies going on with CBD right now. It might turn out that it works. We just don't know yet. I imagine I have quite a few colleagues studying it. I imagine sometime in the near future, we'll see some scientific articles about that, and then we'll know. Same thing with magnesium, all the over-the-counter, sort of so-called natural drugs. First of all, often we don't know what's in the bottle or in the pill. They say it's magnesium, who knows what else is in there. Same thing with the melatonin. Often it's got other things with it as well. We do have a lot of data on melatonin. The data show that it's not a particularly good sleeping pill. Again, if you're using it and it helps, that's great. Melatonin's pretty safe. But in general, has not been shown. And the same thing with magnesium. And you have to be careful with all these over-the-counters. They also have side effects. So before you start taking any of them, if you're under the care of a medical doctor, you should talk to them about whether it's safe for you to be taking those drugs.
Yeah, that sounds like really good advice. I know regards to supplements, it's not necessarily regulated, right?
No, they're
Of
not.
what's
That's
in
right.
it and all that. So we do need to make sure that we're staying safe with those. We do have a question from our very own Rachel. So Rachel, if you want to unmute yourself, we can have a chat with Dr. Ancoli Israel here. I'm going to just add you to the spotlight.
Yay, thank you. What is your opinion on the snooze button? I know personally for me, I tend to snooze way too many times when my first alarm wakes up. And then I think after maybe I've snoozed like 5 times, it's 30, 45 minutes later than I was supposed to wake up. I'm sure that affects my alertness.
Yeah, using the snooze button even one time is one time too many. I don't like the snooze button. Set the alarm. So what you described is a little different. You're saying that your alarm goes off, you should be getting up, but then you snooze for 45 minutes.
Mm-hmm.
And I'll address that in a minute. But what most people do is they set their alarm a little early so that they can then snooze. Set the alarm for when you need to get up, because every time the snooze button goes off, it's waking you up and you're disrupting your sleep. So you want to sleep as long as you can until that point that you're supposed to get up. So when the alarm goes off, that means you're supposed to get up. Now, what you're doing is you're snoozing because you're not quite ready to get up yet. My guess is you're going to bed too late. And you're not getting your 7 to 8 hours of sleep, which is why you're still sleepy in the morning. So setting your alarm to get up is a good thing because you want to get up at the same time every day.
Mm-hmm.
But and I don't mean necessarily for you, Rachel. This is general discussion. You should be going to bed when you first get sleepy, which my guess is earlier than when you're actually going to bed. What most of us do is we're tired, but I still have to finish cleaning the kitchen and I got to do this and I still have work to do, or I really want to blah, blah, blah. And you're not going to bed when you first get sleepy. If you did, then when your alarm went off in the morning or when you were supposed to wake up, you would probably be ready to get up. So try to stop snoozing. Try when that alarm goes off, get out of bed. And what that will help do as well is help your sleep drive begin to increase earlier. So at night, when you're ready to go to bed, you'll have an easier time falling asleep.
Awesome.
Yeah, sounds good. Thank you. So we're going to have time for a couple more, for maybe 2 more questions if anybody has any. I do have one more here in the chat that I want to bring up. So I'm going to leave some more time for 1 or 2 more questions to be submitted. But the other question is, with regards to sleep apnea, and Dr. Ancoli Israel mentioned it really briefly at the end of your talk there.
Mm-hmm.
It seems like a lot of the treatment options are more management. are there ways to actually improve sleep apnea, or are there other options other than a CPAP type of machine to help us with that?
Right. So the gold standard treatment for sleep apnea is a PAP machine, positive airway pressure. It's a mask that you wear connected to a machine that pushes positive pressure through the airway, which acts as a splint to keep your airway open during the night. There are quite a few other treatments available now. If you're having a difficult time with your PAP machine, talk to your sleep doctor, because they might be able to recommend a different treatment. Also, if you're having trouble with your PAP machine, it's really about the mask. There are now literally hundreds of different masks out there. The companies tend to give you one mask. Keep asking for a different mask until you find one that's comfortable for you, and that will help you adjust to your PAP machine. There's no way to prevent sleep apnea, really. It's really all about treatment. Weight loss might help a little bit, and it's always good to lose weight if you're overweight. But it doesn't usually cure the sleep apnea. So really the best thing is you have to have it treated. There are surgeries, they often don't work very well. I don't recommend them.
Yeah, sounds good. Thank you. And I think the question really was asking, I mean, there are other mouth devices that we've used.
Right.
It seems like maybe asking for other devices or
That's
other
right. There
adapters
are
for
oral appliances, especially if your apnea is mild or even moderate apnea, can respond to oral devices that sort of pull your chin forward, which enlarges the airway. Truly, there are quite a few different treatments available now that you could explore.
Awesome. Thank you. And so I wanted to make sure we ask two last questions. The one question is coming actually from a former student of ours, and he's currently on to bigger and awesomer things. I don't know, JP, since you submitted in the chat, would you mind just asking that in person as well? I'm going to add you to the spotlight. You can unmute yourself and ask that question.
Yeah, definitely. So obviously I'm a former student, PT student. Oftentimes we do have patients after surgery or after like a major injury that are in pain and have trouble sleeping because they say that, the pain wakes them up through the night and things like that. Do you have any recommendations for what we can tell these patients as far as tips for improving their sleep? Or is this just part of the process after, say, like a major surgery? It's kind of expected.
Well, it's expected, but that doesn't mean you shouldn't do anything about it, because you run the risk of them developing some bad habits, and then that would perpetuate the insomnia even once the pain goes away. But as I mentioned briefly at the beginning, it's really important to treat both of them at the same time. You can't assume that because you're treating the pain, the sleep will necessarily get better. So deal with both. Definitely treat the pain, but work on the sleep as well. And it could be with some of the behavioral, or you might want to use a short-term sleeping pill to help them get their sleep. I would work in combination with their physician, their surgeon, someone who can help you decide what is the best approach. The behavioral stuff you can do with the patients. You can advise them on all the different behavioral things that we talked about and start with that. The thing is, if you're in a lot of pain, it's sometimes a little harder to get out of bed and do things like that. So you have to modify it to make it work for the patient.
Yeah.
Awesome. Thank you.
You're welcome.
And thank you. And that's such a big topic for us from a physical therapy perspective. One of my questions actually was related to that in terms of chronic pain or persistent pain and how that is related to sleep. And it does sound like treating it multidisciplinary approach is the best way to go, making sure we address things on all ends.
And remember as well that many of the pain medications are sedating. They tend to make you sleepy. So taking those at night is a perfect time, because then it might help the person sleep as well as dealing with the pain.
Yeah, perfect. And so with that, actually, my last question is from a multidisciplinary approach. Dr. Ancoli Israel, do you have any physicians or any sleep researchers who we can maybe refer our patients to, or our patients can look up so that we can if they are having trouble sleeping, have some form of an expert
Sure.
help
Well,
them with
given
this.
that I'm at UCSD, of course, I'm going to recommend them first. UCSD has a wonderful sleep medicine center. I used to work there. I don't see patients anymore because I'm retired, but there's a whole slew of wonderful physicians and psychologists there who treat all different types of sleep disorders, including doing the behavioral treatments. So I highly recommend them. There are many other sleep physicians in town, so look at what's most convenient for you. But any sleep medicine center has professionals, doctors who can help you with your sleep.
Oh, perfect. Thank you. So with that, everybody, I want to take this time to just thank Dr. Ancoli Israel for coming in and speaking with us. It's such a great honor and pleasure to have her here sharing on this topic, which she's been immersed in for so many years. And I know on my end as a physical therapist, and I'm appreciative of JP being here, of Jackie being here, this is the next step to really physical therapy as a comprehensive approach, is making sure we are talking about all these different things that are affiliated with our healing process, with our body recovering, with stress management, all these different things. So for those of you out there who may not have had a time to ask the questions, please make sure you can send them to me, and I'll collate them and send them back to Dr. Ancoli Israel. Or if you personally are dealing with some of these sleep disturbances along with some physical therapy related troubles, pains and aches, please let us know. We do offer our one-on-one free consultations where we can talk to you about some of these things, finding some of these behavior things that can work well for you. And if not, we now have some resources we can refer to. Yes.
And I'm going to give my testimonial. So Joe is my physical therapist. I had some knee surgery, and it made such a difference in my life. So yeah, if you're in pain and having problems, go for it.
Perfect. Thank you. Thank you. So with that in mind, everybody, please be on the lookout on Monday for an email with a PDF of some of these slides in there, as well as we do have a survey that we encourage you all to fill out, because it does help us to improve these seminars for you all. If there's any other topics you'd like to hear about, please let us know. Rachel's our marketing coordinator. She and I are putting together these seminars for you. This is for you all. So if you have any topics you'd love to hear about, please let us know. Our next one coming up in April is going to be on the topic of pelvic health. So more specifically, women's pelvic health with regards to pain, dysfunction, things along those lines. So be on the lookout for some more information. And once again, I want to thank Dr. Ancoli Israel, and we're going to finish our time here. Thank you everyone for attending, and we hope you found this to be helpful. Thank you.
Bye-bye. Thanks.